Well, hello and welcome to another episode of Coffee Talk with Encore. Today we'll be discussing how to code section GG when using the not applicable and not attempted codes. Although we will be seeing some changes within the content of the section GG self-care and mobility item sets, with those updates that are going into October 1st, the coding for those two sections, however, did not change. And with that said, today's discussion should be a review for some and a clarification of the coding for others.
When we're talking about the not assessed levels for section GG, there are 4 of them that we are able to code. So this is when we weren't able to assess a task. And it's very important that we're actually coding the correct reason on why we were unable to assess that. So the first one we have is resident refused. This is where they just flat out refused to do a task, and it had nothing to do with a medical reason or anything like that. They just said, I'm not going to do that for you today. And we do know that sometimes that happens. The next one that we have is not attempted due to medical condition or safety concerns. So this is used when we can't complete a task because of, like in the definition, a medical condition or a safety concern. Maybe they're too fatigued. Maybe they don't have the physical strength to complete the task and they're saying, I wish I could, I just cannot do it today. Maybe there's a situation where it would just be very unsafe for us to attempt a certain task. You know, if they are at a point where we're having difficulty with sit to stand and it's requiring 2 people, assessing stairs is not something that we would want to do. All right, next we have not attempted due to environmental limitations. So this is used when the environment doesn't lend itself to what we need to assess. So maybe there's some crazy weather outside and we're unable to take our patients outside to participate in a car transfer or something like that. It can also be used when the patient is in isolation and maybe we're unable to assess stairs. Now, it's always important that we try to assess it, but if we cannot, we would use that not attempted due to environmental limitations. This code is also reserved for when someone has an AFO at home or something like that, some sort of piece of equipment, maybe a prosthetic, and they haven't brought it into the facility yet, so they just don't have it with them at this time. We would also use the not attempted due to environmental limitations in that situation as well. And lastly, we have NA. This is used when the task just simply isn't applicable to the patient. So maybe they haven't walked in 10 years. We don't anticipate that they're going to be walking during the plan of care. We don't anticipate that they're going to be doing it after. It's just something that, again, they didn't do it before. We're not going to be focusing on it. So it's just not applicable to the patient.
Yes, with those those coding errors that we do see, we need to just keep in mind those 4 coding areas when we're unable to assess that on day 1. So we do often see dependent coding when it's not appropriate. So the definition from the RAI manual of dependent is when you, as the therapist or the helper, are completing all of the task or the effort for that task completion, or if that patient requires 2 people to assist in that task. So that really means dependent coding is not appropriate if the patient was unable to complete the task. We also see a lot of incorrect use of not applicable. So keeping in mind that definition that Kelly just talked about, if the patient has physical limitations, if they refused, or you just couldn't get to that area that day, you need to use another category because we're telling the reviewers and CMS that the patient didn't need to complete this particular area in that task because maybe we potentially won't address it. And in actuality, maybe we will. So another common area that we see coded incorrectly is refusals. So if the patient was too fatigued to complete the task, we really need to know the why behind the refusal. So if the fatigue is due to the patient just not wanting to complete that task and they're like, nope, not doing that today, then you can certainly use that refusal. But if they're fatigued because of a medical condition, we can certainly code for not attempted due to medical or safety.
So it's really important that we get this coding correct, especially on our admission and our discharge scores. There's sometimes, in the middle of the plan of care when we're thinking about why didn't we do it today or why hasn't it been happening in the last week where it's not quite as important. But when you're looking at that formal admission assessment and discharge assessment, it's really important that that information is coded accurately. It's being submitted on the MDS assessment, it's being sent up to the federal government, and they're looking at it. And when the surveyors come back into your facility, they're looking to check the accuracy of those assessments. The other key is that this information is being used in the facility's quality measures. So when we look at how your facility is going to compare to other facilities, we have to understand how those calculations work. And CMS is changing the quality measures a little bit this year. We're going away from that change in mobility, change in self-care score, and going towards the DC function. But what that means is that there's a computer system predicting how your patient is going to do on discharge, and then judging your facility by whether or not they made it to that functional outcome. And in the past, the computer system took all of the scores for the not attempted, not assessed, not applicable, and made them a dependent. Now, the new computer system is taking that information and it's actually trying to estimate what the score would have been if you had attempted the task. So there's a big difference in that estimation if the patient couldn't do the task because they weren't medically able. So their COPD was so severe that they couldn't get up and walk, versus their behavior was a problem and they refused to get up and walk. So when you're thinking about how the AI, which I assume is an AI system of some sort, how that computer system is managing that data and how it's predicting what's going to happen, and then it's using that to estimate what your discharge summary is going to look like, we want to make it as accurate as possible on the admission. And then we want to make it as accurate as possible on the discharge so that we get scored correctly. Additionally, a lot of our EMR software, if we put in that not applicable, it actually removes that item set for the rest of our stay. So when we're looking at making sure that we code everything we need to code on discharge, it's not even going to show up. So even if we did address it in our goals, it's not going to be there for us to fill out. And so then we're going to cheat ourselves out of those extra points at the discharge. So we just need to make sure that it's coded accurately.
Super good points for sure. You know, there's a lot of things that clinicians do need to be aware of when they're coding for each of the section GG item sets. You know, today specifically, we're talking about self-care and mobility items, both at the time of the evaluation at discharge, as we've talked about, must be accurately completed because of that ripple effect. If we don't, it's certainly going to make an impact on that patient and their stay, and really us being able to justify the services that we want to provide during the course of our therapy treatments. We really want to keep in mind also that many of the coding levels that are documented by therapists, just as Becky said, they are used within the MDS assessment. And then when that assessment is utilized, we share it with CMS. Medicare is reviewing it. It's really important that we are supporting therapy as well as other health services that the patient's receiving during their skilled stay. So that being said, you know, due to the importance of the accuracy in coding these items, it's extremely important that those who are entering the coding levels into the medical record, they are truly being mindful of what they are documenting and what they're coding. You know, the codes that clinicians choose, they can make a difference in really accurately telling the patient's story, so to speak, within the MDS assessment. Well, I'd like to thank everyone for joining us today and listening in to hear our discussion on how to code section GG when using the not applicable and not attempted codes. And we look forward to having you tune in again for our next episode of Coffee Talk with Encore.